Thank you. Thank you for the opportunity. And this is a multidisciplinary topic. Sorry. 1 minute, 1 minute. So this is the topic is a clinical presentation, imaging characteristics, and treatment outcome of patient diagnosed with carotid cavernous fistula. So a carotid cavernous fistula is an abnormal connection between carotid arterial system and cavernous sinus. This arteriovenous shunt disrupt normal hemodynamics, increase venous pressure, and causing a range of ocular and neurological symptoms. CCF characterized by mainly presence of pulsatile proptosis, conjunctival chemosis, orbital bruit. These are also known as Dandy's triad. Coming to the classification, usually it is classified into a direct and indirect. Direct is high flow and indirect is a low flow. Again, it is by Burroughs, it is classified into type A and B to D in indirect. But in all types of arterial blood bypasses, the capillary bed and enter the venous system, resulting is bypass the capillary bed and enter the venous system, elevated pressure with cavernous sinus. So this impair venous drainage, especially from the orbit in anterior draining fistulas, leading to ocular symptoms. So the etiology mainly of kind of it's a trauma, but direct mainly it is a complication. It's no doubt it's a rare complication, but mainly the craniofacial trauma, motor vehicle collision, fall, penetrating injury, and mainly fracture of the base of the skulls lead to the CCF. And it can be also spontaneous, mainly in postmenopausal women with hypertension, connective tissue diseases, often due to rupture of intracavernous aneurysm or we can atherosclerotic vessels. And indirect, which develop more gradually and more commonly in elderly and may arise from the dural artery rupture or venous thrombosis. Ocular presentation mainly decreased vision, conjunctival chemosis, proptosis, pulsatile proptosis, diplopia, orbital pain, and audible bruit will be there. The symptoms are caused by retrograde venous drainage into the ophthalmic vein and lead to episcleral and conjunctival arterialization and restricted ocular motility and exposure characteristics. So diagnosis mainly depends upon the radiology imagings, CT, MRI, along with that, but angioCTs, that is angiography, remain the gold standard for the definitive diagnosis and classification, DSA. So management, the management mainly nowadays is the endovascular therapy has become the preferred first line treatment for cardiovascular, that is CCF, due to minimally invasive approach, high efficacy, favorable safety profiles, and choice of endovascular technique depends upon the fistula anatomy. Coming to my cases, this is the first case of 36-year male with a one right eye developed with CCF that is after 1 month of road traffic accident. The visual acuity is 2/60, IOP is 24, and curved disc ratio is 0.8. And there is a proptosis with chemosis, and there is a restriction of movement in the cases. And also we find on palpation there is a bruit observed with this is mainly the upper medial canthus area in the upper lid area. So on ultrasonography we say dilated superior ophthalmic vein, and on CT also we found there is a dilatation of ophthalmic vein SOV, and DSA we found there is a dilatation of superior ophthalmic. There is dilatation of superior ophthalmic vein SOV. And initially, first, mainly in the direct one, initially you start with a transarterial negotiations. And this transarterial negotiation, due to the acute angle of this rent, it is little bit difficult. So we give up. Again, we go for a transvenous negotiation. So in transvenous negotiation, we are able to this with this coil, thrombogenic coil, we are able to this obliterate the rent. And post this thromboembolisms or endovascular, there is no rent. This is a pre and post embolic photos of the, and Immediately after, this is the immediately after photograph procedure. And this one is after 7 days. And there is the vision, IOP, and the restriction of movement all are subside. This is another case two of a direct, this is also direct CCF after trauma, almost like same. And here also successfully this is obliterated with with this endovascular thromboembolism. And this is a case 3, this is an indirect one. Then with MRI, we find a dilated left superior ophthalmic vein, and digital subtraction angiography show indirect carotid cavernous fistula with a feeder branch of both external and meningeal branch of bilateral cavernous internal carotid artery. So here also successfully, but in indirect we go mainly through the petrosal sinus. So here there is a there is a uh, there is a dilatation of the superior ophthalmic vein here, and this is a procedure through negotiation of microcatheter intracavernous sinus through the intrapetrosal sinus, and successfully it is negotiated, and postoperatively this dilated this superior ophthalmic vein is totally, the block is total, rent is totally obliterated. Coming to the case 4, this is a 68 female present with left redness, proptosis 6-month duration, DSS showed a right cavernous sinus refluxing into left cavernous, and there is a interconnection between cavernous connections. So it is also successfully been negotiated with the endovascular procedures. And but in some cases also, you can also manually compression can be solve your problem without doing any endovascular. This is a case with means manual compression. There is a dilatation of SOV, and again in post operation post manual compression, this been okay this been obliterated. So the take home message, CCF is potentially vision threatening conditions with significant ophthalmological complications. Timely diagnosis and interventions are crucial to prevent morbidity and mortality. Advanced imaging and treatment technique have improved outcome, but complications remain a concern. And ophthalmologists play a pivotal role in the multidisciplinary management of CCF, ensuring optimal care for affecting patients, starting from the diagnosis and evaluations and procedure also you are assisting there, and also in follow-up again. So thank you. This is my.
Thank you, Dr. Sandip. It was a very nice presentation and variety of cases you have shown. I just want to ask about the visual prognosis of the patient, which I guess the patient had come very late to you, like 1 month, 2 months. So just the proptosis been resolved, but did the patient recovered visions?
Sure, sir. The first case, the patient present to us after 1 month.
Yeah.
And second case, it was presented after 2 months. But even also after 1 month, even the COP disc was become 0.8 there in fundoscopy. Still also the visual prognosis is 618 after 7 days, 618. And after when we come after 2 months, it is almost with best correction visual acuity is almost 6.9 part. So visual correction is a very dramatic in endovascular procedure. In the patient, as early the patient will come, the prognosis is better. Okay, but when the patient will come later, this due to even also 0.8 it is about, there may be some defect of visual fields, and there may be a decrease in the visual acuity. But in our case, after 1 month also the prognosis is good. And second one, it's 624 after 2 months.
Okay. So
any
wonderfully presented series, Sandip.
Thank you,
and
ma'am.
such beautifully shown coiling and all. The third case that you showed was an
indirect
he was a young patient.
Young
Usually
patients, 24-year male.
Yes, because we usually, when we read
Exactly,
up and
ma'am.
everything, we say indirect is in older patients and spontaneous, not related to trauma. So was that patient spontaneous or was
That
it
was
a
spontaneous, but young patient.
young patient?
Usually, young patient do not have a spontaneous one. Spontaneous usually in postmenopausal after 50 decades, and if the patient have any connective tissue disorder. But this patient is a atypical one, so it have indirect one. Indirect, first thing also, even you only you will find a corkscrew vessels. There will be nothing else. Even proptosis will be also not there. Diminution vision, unilateral there may be a copper disc 0.6, and there is a diminution of vision, and there is a corkscrew vessels, dilated and tortuous
That's very
vessels.
interesting. So we may be missing a few patients which actually have
Huh.
indirect CCF in younger patients presenting just with corkscrew vessels. So I think we
Exactly,
should be
madam.
doing
If it
more.
is a resistant, treatment resistant, and you are finding dilated unilateral and dilated, then it should evaluate radiologically.
And the manual compression I did not really get because you were saying in the last slide. So can you just explain the manual compression
Manual
technique?
compression, this is the mainly internal carotid artery. You should compress that, and maximum time will be 5 minutes according to patient. Tailor, it's a tailor cut. It's the means according to patient, and you should ask the patient to have a other eye. Suppose it is a right side, then you have to means you have to use the left hand. Why? Because our brain have a means this pathway is to other way, na? So right side of half is means means it's by the left one and left by the right one. So when there will be little bit ischemic, then there will be it's automatically the hand will be fall up. So that is a one tricks you have to use, and maximum time should be 5 minutes, and it should be less also according to the patient. And if you will manually compress that one, then the patient will be some patient, few patient there may be obliterated. The obliteration of this rent will be there. But if you will fail, then again you should go for endovascular procedures.
So this obliteration is for temporary or like?
No, this is permanent. Again, also according to size, that is a good question actually, madam. I want to explain that one. So it is the size. Okay, we are using previously we are using balloon, and now we are using thrombogenic coils. Okay, thrombogenic coils, and also you can have a thrombogenic liquid inside. So here also we use the balloon, but it is not detachable balloon. Balloon is only to protect the internal carotid artery so that the thrombogenic things will be not go and occlude it, and there will be a cardiovascular accident. So again, if the coil is the size of the coil is lesser, then you can use the adjuvant thrombogenic liquid also there. So even also it's a too bigger one and it's unsuccessful with endovascular, then open surgery for neurosurgery you can go for.
Very nice. Any question?